Hi everyone, Peter Johns here, emergency physician and vertigo enthusiast. BPPV is the most common cause of vertigo, and the Dix-Hallpike test is the most useful bedside test to diagnose it. Everyone seems to agree on that, but what happens when you look up the sensitivity and specificity of the Dix-Hallpike test?
You might see something like this. On UpToDate, it says that the sensitivity of the Dix-Hallpike test is between 50 and 88%. That seems a bit surprising, given that it's supposed to be the gold standard. Or you might search for the most recent Cochrane review and find this: a sensitivity of 79% and a specificity of 75%. Specificity of only 75%, so if you see a positive Dix-Hallpike test, then there's a 1 in 4 chance that the patient doesn't actually have BPPV? Should we even really be doing the Dix-Hallpike test? The ultra-quick answer is yes, and that's because the Dix-Hallpike test is the gold standard for diagnosing posterior canal BPPV, and the studies that were said to measure the sensitivity and specificity of the Dix-Hallpike test compared the Dix-Hallpike test, a gold standard test, to a very tarnished reference standard, leading to meaningless results. So who says that the Dix-Hallpike is the gold standard for diagnosing BPPV? Back in 2003, Canadian ENT surgeon Lauren Parnes wrote in an excellent review of the topic in the CMAJ that the history and eye findings during positional testing are the gold standards for diagnosing BPPV. That is, in a patient with a history consistent with BPPV, do the Dix-Hallpike test. If it's positive, you have a gold standard diagnosis. In 2008, Fife, along with other legendary vertigo researchers and clinicians such as Lempert, Balow, Furman, and Hain, stated in their evidence-based review of BPPV that they only included articles that met certain criteria, and the first criteria was that in the articles included, BPPV was diagnosed by provoking vertigo and seeing the characteristic nystagmus during the Dix-Hallpike test, or other positional tests, as I'll tell you about in a minute. Then, in 2014, Kim and Z, in this New England Journal of Medicine Clinical Practice Review, wrote, and I'll paraphrase it slightly, the Dix-Hallpike test is the standard for diagnosing posterior canal BPPV, as long as you see the right kind of nystagmus. And what is the right kind of nystagmus? I'll show you that in a minute also. Here is Kevin Kerber, another excellent vertigo researcher and clinician, saying the same thing. And finally, David Newman-Toker of the HINTS exam fame also agrees that it's the gold standard. By the way, don't do the HINTS exam on patients with suspected BPPV. See the link on the screen for a video explaining why that is true. And I can assure you that nowhere in the accompanying text to the publications I just showed you is there reporting of the sensitivity or specificity of the Dix-Hallpike test, just that the Dix-Hallpike test is the gold standard. So what is the backstory for why UpToDate and the Cochrane review cite such a range of not very gold standard numbers for their sensitivity and specificity? I already gave you the ultra-short answer that the Dix-Hallpike test is the gold standard, and that any study attempting to measure the sensitivity and specificity of it are flawed by design. So now I'll give you the medium-length answer, as well as show you the nystagmus seen in a positive Dix-Hallpike test and how I suggest you use the Dix-Hallpike test in practice. And if you have the stomach for it, I'll also show you the data from the original papers that purportedly show the sensitivity and specificity of the Dix-Hallpike test. To diagnose BPPV, first you have to suspect it, and the way you do that is to take a history. And the patient should describe short episodes of dizziness, lasting generally 20 or 30 seconds, which are brought on by things like getting into bed or getting out of bed or rolling over in bed. If they keep still, the vertigo pretty much goes away. Some patients will say they feel a bit dizzy even when they stay still, but nothing like when they roll over in bed or get in or out of bed. And they shouldn't have any other new neurologic accompanying features. And importantly, you shouldn't see spontaneous or gaze-evoked nystagmus. Once you've suspected that they might have BPPV based on their history and lack of nystagmus, it's time to apply the gold standard test for posterior canal BPPV, the Dix-Hallpike test. And here is what a positive one looks like. In this woman, we are testing her left downward ear. After a brief period of latency where nothing happens for several seconds, you now see a crescendo-decrescendo pattern of nystagmus, which is rotatory towards the downward ear and vertical upwards. It lasts roughly 12 seconds. In slow motion, you can see the vertical upward and rotatory nystagmus. Some call it upbeating, but I prefer to say vertical upward to emphasize that vertical upward nystagmus is the expected finding in a positive Dix-Hallpike test, and not at all concerning for a central cause of vertigo. Now, spontaneous vertical nystagmus, that's very concerning for a central cause. In this patient, also testing the left ear, we see that if the patient looks towards their downward ear, the nystagmus becomes mainly rotatory, and if they turn their gaze towards their upward ear, it becomes more vertical. If you want to see a bunch of positive Dix-Hallpike tests, then click on the link on your screen for a video I made demonstrating just that. So a history consistent with BPPV in combination with a positive Dix-Hallpike test makes the gold standard diagnosis of posterior canal BPPV. But there is more than one semicircular canal that those little ear rocks can get into, and for horizontal canal, the next most common type of BPPV, the supine roll test is the gold standard for diagnosing it. You simply lie the patient supine and then turn their head 90 degrees to one side, and if it's positive, you will see horizontal nystagmus beating towards the ground. Now this gentleman's left ear is towards the ground, and his nystagmus is also beating towards the ground. This is called geotropic horizontal canal BPPV. Sometimes it'll be beating away from the ground on both sides, and this is called apogeotropic horizontal canal BPPV. So going back to the sensitivity and specificity of the Dix-Hallpike test, it's a catch-22. Trying to measure the sensitivity of the Dix-Hallpike test on its own is impossible because you can't make the diagnosis of posterior canal BPPV without a positive Dix-Hallpike test. But certainly the Dix-Hallpike test is not always positive the first time you do it on a patient with BPPV. Repeating it, either in the same visit or testing on other days, will sometimes show a positive result even when the first time was negative. So the sensitivity of the Dix-Hallpike test is definitely not 100%, but what it really is not known. So that's why most current vertigo experts don't bring it up and just say it's the gold standard. Now what about the specificity of the Dix-Hallpike test? That is, how often do you get a history consistent with BPPV and then you see a positive Dix-Hallpike test with the features I just showed you and it turns out to be something other than BPPV? The answer is exceedingly rarely, if ever. So in practice, if you see the typical nystagmus in a Dix-Hallpike test with a typical BPPV history, then it is posterior canal BPPV, especially if you can cure it with the Epley maneuver. So the specificity is very close to 100%. Practically, this leads to this suggested approach. If you have a patient with a history consistent with BPPV and the general and neurologic exam reveals no abnormality, and that includes no spontaneous or gaze-evoked nystagmus, then perform the Dix-Hallpike test. If it's positive, then treat the patient with the Epley maneuver. If the initial Dix-Hallpike test is negative, or if you see horizontal nystagmus, then perform the supine roll test to see if the patient might have horizontal canal BPPV. And if it's positive for that, then you can use the Cohen maneuver to treat the horizontal canal BPPV. If the Dix-Hallpike test and the supine roll test are both negative, but you really think it's got to be BPPV, then repeat the Dix-Hallpike test. If it's still negative, either they had BPPV, which has spontaneously resolved, which is not uncommon, or it is BPPV, but they're just not testing positive today. They can be sent home and cautioned to be reassessed if they develop other episodes. And of course, they may not have BPPV, but patients having brief episodes of vertigo initiated by head movements and have no other neurologic symptoms or abnormal findings and have negative Dix-Hallpike and negative supine roll tests have a low risk of bad things happening, and they are safe for discharge with follow-up as necessary. Now for most people, that's all the information you need to know, but there'll be some of you who are still wondering about the history of the original papers that are supposed to reveal the sensitivity and specificity of the Dix-Hallpike test. And for those of you coming along for the ride, strap yourself in. Here is the long answer. To determine the sensitivity and specificity of a diagnostic test, the diagnostic test has to have a defined positive or negative result. The Dix-Hallpike test certainly has that, so far so good, as we just defined what a positive Dix-Hallpike test is. Next, to determine what the answer is for the sensitivity and specificity of the Dix-Hallpike test, you have to compare it to another validated gold or reference standard way of determining the diagnosis of BPPV that doesn't include the Dix-Hallpike test. And there isn't one. So let's go back to UpToDate and its reporting of the sensitivity of the Dix-Hallpike test to be 50 to 88%. This page of UpToDate is written by Dr. Barton, a professor of neurology at UBC in Vancouver, Canada. The references he gives is Hoffman from 1999. Well, it turns out Hoffman merely quotes 3 other papers to obtain his 50 to 88% numbers. The first paper is by David Froehling from the Mayo Clinic. This is where Hoffman got his lower 50% number for the sensitivity of the Dix-Hallpike test. This 35-year-old study was a retrospective review of population-based medical records that found 53 patients diagnosed with BPPV in 1984. What was their gold or reference standard method of determining the diagnosis of BPPV against which the Dix-Hallpike test could be tested? It was the main author and internist who retrospectively reviewed the charts, and if the patient had transient episodes of vertigo that occurred only with changes in head position and had no other neurologic signs or symptoms as determined by the chart, then boom, that was the gold standard diagnosis of BPPV that the Dix-Hallpike test was compared against. It was clearly stated in the paper that positional nystagmus was not required to make the diagnosis of BPPV. Of the 53 patients they found by chart review to be suffering from BPPV, only in 26 patients could they find that a Dix-Hallpike test had been documented in the chart, and of those, 13, or 50%, had had some kind of nystagmus seen. But it doesn't say if the nystagmus seen was in keeping with the diagnosis of BPPV. And that, my friends, is where Hoffman, and by extension up to date, gets the 50% lower number for the sensitivity of the Dix-Hallpike test. The other 2 studies that Hoffman uses for his 50 to 88% sensitivity for the Dix-Hallpike test were both conducted at a dizziness clinic in Montreal, Canada between the years of 1974 and 1988, and both have Kasarkas as an author. In the earlier 1978 study by Kasarkas, he studied 255 patients diagnosed with BPPV, but the diagnosis was based on history alone. That is, they really were only suspected BPPV patients. In the paper, he states, all the patients gave a definite history of episodic short-duration vertigo occurring when lying or turning from side to side in bed or hyperextending the head or bending over. And he found that 188 out of the 255, which is 73%, had a positive Dix-Hallpike test. But this is not a report of the sensitivity of the Dix-Hallpike test. What it actually is the percentage of patients with suspected BPPV by history that were confirmed to have it by the Dix-Hallpike test. Kasarkas did not report this in his paper as the sensitivity of the Dix-Hallpike test, but for some reason Hoffman thought it did. Last of the papers that Hoffman referenced from his 50 to 80% sensitivity of the Dix-Hallpike test was Bloom and again Kasarkas from the same Montreal Dizziness Clinic, but from 1989. This paper looked at 328 patients over the age of 70 with a history of strongly suggestive of BPPV. Of these, 131 had nystagmus typical of posterior canal BPPV. That's only 40%. But again, this is not the sensitivity of the Dix-Hallpike test, only the percentage of patients suspected of having BPPV by history that turned out to have it. And Bloom, the lead author, knows it too, because in his second last paragraph of his paper, he states, the diagnosis of BPPV can be suspected by history but cannot be confirmed unless one provokes the paroxysm and observes the elicited nystagmus. So he admits that the reference population studied was only the suspected BPPV patients and not confirmed BPPV patients. So none of the 3 studies that Hoffman used to back up his statement of 50 to 88% sensitivity of the Dix-Hallpike test compared the Dix-Hallpike test to a valid reference standard diagnosis of BPPV, but it's still there referenced and up to date. Next up is the Cochrane library. The most recent Cochrane review that mentions the Dix-Hallpike test is by Hilton, an ENT surgeon from the UK. In a systematic review of the Epley maneuver that was updated in 2014, he states the sensitivity and specificity of the Dix-Hallpike test is 79 and 75% respectively, and he cites Halker's paper from 2008 for this information. Halker is a neurologist from Arizona. As I mentioned earlier, if these numbers were true, a specificity of 75% means that a quarter of the patients with a positive Dix-Hallpike test don't actually have BPPV. Again, the specificity of the Dix-Hallpike test is thought to be very high, approaching 100%. So how good was this data from Halker for her to make this statement? First of all, they declared that the Dix-Hallpike test is, in fact, the gold standard for the diagnosis of BPPV. Then, Halker only looked at the data from one study, the Cohen study. And the Cohen study was, as admitted by Halker, Unfortunately, a very poor study. Still, Halker went on to extract data from it to produce the numbers that appear in the Cochrane review. So what did the Cohen study look at? A dizzy clinic studied 61 patients who complained of positional vertigo and who were referred by ENT surgeons or neurologists for further diagnostic testing. They had the Dix-Hallpike test and the side-lying test performed on them. What was the gold or reference standard diagnosis to which these tests were compared? This is again the problem with this study. They managed to come up with the diagnosis only 35 out of the 61 patients, and the reference standard diagnosis was that if the patient had been seen by one of the ENT surgeons in their department, they found the diagnosis in the patient's chart. Or if the patient was referred back to their department for rehab, they took the diagnosis that was on the prescription for rehab. And 31 were diagnosed with BPPV, and Cohen reported the results from 29 patients. It's not at all clear whether results of the testing performed were available to those who made the reference diagnoses. If you're already thinking that this gold standard diagnosis was a little shaky, then it's worth mentioning that the author removed one subject from the study because that patient, and I quote, had been seen by a physician who always uses the diagnosis of BPPV for patients with vertigo of a peripheral origin. This left them 29 patients for the reference standard who were diagnosed in quotation marks as having BPPV, against which the Dix-Hallpike test and the side-lying test was compared. Halker, despite her misgivings about the quality of the very weak methodology by Cohen, went on to construct a 2x2 table which gave her the 79% sensitivity and specificity of the Dix-Hallpike test. Since we know specificity is calculated by the true negatives divided by the true negatives plus false positives, we know that the numbers by which they calculated the specificity were 3 true negatives and just one patient who was declared a false positive. So the reason why the Cochrane review lists the specificity of the Dix-Hallpike test as only 75% with a 95% confidence interval of 33 to 100% is because one patient who had a positive Dix-Hallpike test had another diagnosis written on their chart, and how that diagnosis was actually determined is not at all clear. So if we trusted the reported specificity, it could be that the specificity is actually almost 100% as I contend, or it could be very bad where 2 out of every 3 positive Dix-Hallpike tests are actually false positives. By now I hope you see that this study shouldn't be quoted as helping answer the question of the sensitivity or specificity of the Dix-Hallpike test. I'll leave you with one last kick at the can of what is the sensitivity and specificity of the Dix-Hallpike test. In his excellent clinical practice guideline for BPPV, which was updated in 2017, Bhattacharya, an ENT surgeon in Boston, again states that the Dix-Hallpike test is considered the gold standard test for the diagnosis of posterior canal BPPV. He then states that the lack of an alternative external gold standard to the Dix-Hallpike test limits the availability of rigorous sensitivity and specificity data. Well, we agree there. That's the whole point I'm trying to make in this video. But then, just a few words later, he inexplicably references a paper trying to do just that. He reports that Lopez-Escamez found a sensitivity of 82% and a specificity of 71% for the Dix-Hallpike test. Dr. Lopez-Escamez is an otologist, so an expert in vertigo in Granada, Spain. In this study, 100 patients who complained of dizziness or loss of balance were evaluated using a structured clinical interview. Afterwards, the results of the questionnaire were examined by 3 blinded investigators who assigned a diagnosis to these patients. Of the 100 patients, only 13 were given the diagnosis of BPPV. From these mere 13 patients, they determined the sensitivity and specificity of the Dix-Hallpike test to be 82 and 71% respectively. Now, the only way to get a specificity of 71% with such small numbers is you got 5 out of 7, which means there's 5 true negatives and 2 false positives found. So in these 2 false positive cases, the Dix-Hallpike test was positive, but the blinded investigators said, after looking at the structured clinical interview questionnaire, they looked at the results and said, no, that's not BPPV. Based on these 13 patients and the reference standard chosen to compare the Dix-Hallpike to, I don't think this gives us any useful information about the sensitivity or specificity of the Dix-Hallpike test. Okay, it's time to bring it on home. The Dix-Hallpike test is the gold standard for diagnosing posterior canal BPPV. If the history is consistent with BPPV, but there's no spontaneous or gaze-evoked nystagmus seen, then do the Dix-Hallpike test. But the sensitivity of the Dix-Hallpike test is not 100%. Do the supine roll test if the Dix-Hallpike test shows horizontal nystagmus or it's negative, that is, no vertigo and no nystagmus. But if it really sounds like BPPV and the first Dix-Hallpike test is negative and the supine roll test is also negative, then repeating the Dix-Hallpike test will increase the chance of seeing a positive one. The specificity of the Dix-Hallpike test is close to 100%. If you see the characteristic nystagmus with a presentation consistent with BPPV, then it is posterior canal BPPV. Please cure these patients with the Epley maneuver. The older studies references providing a sensitivity and specificity of the Dix-Hallpike test are not useful due to the difficulty in finding a valid external reference standard against which the Dix-Hallpike test could be compared, which is why highly regarded vertigo experts don't bother reporting the sensitivity or specificity of the Dix-Hallpike test. And finally, if you read a statement that is referenced as fact in a paper, but it sounds a bit suspect, look up the referenced paper. You just might find a few surprises.
For more information on vertigo, be sure to look at some of my other videos, such as what does a positive Dix-Hallpike test look like and how to diagnose and treat horizontal canal BPPV. Thanks for watching.